So hi guys, my name's Chris. I'm a final year medical student at the University of Liverpool. And today I'm just going to be taking you through LFTs, liver investigations relating to when things go wrong with the liver. And we're going to touch on liver failure as well. So let's get stuck in. So as I said, that's what we're going to go through today. Investigating liver failure and looking at LFTs. Acute liver failure and chronic liver failure. It can be quite a dry topic, so I'm going to try and make it as interesting as I can. I will be asking some questions throughout, so feel free to ask questions in the chat, or if you're feeling brave, you can unmute yourself and have a go at answering it yourself. So there's quite a bunch of stuff which we won't be going through just because there isn't enough time in this talk, but that essentially encompasses everything you really need to know relating to the liver for your finals exams, or at least that's everything I went through, and I found that quite helpful. But we'll be focusing on those top three things today. So starting off with the liver, we want to talk about the function of the liver. So do people want to start putting in the chat, what are the main functions of the liver? What's the role of the liver?
So somebody has said making digestive enzymes, alcohol metabolism, albumin synthesis, clotting factors, detoxify.
Yeah, these are all brilliant answers. So first thing is breakdown. So the liver is responsible for breaking down various drugs, toxins that accumulate in the body, such as ammonia and bilirubin as well. It's responsible for the synthesis of a whole host of things, including amino acids, carbohydrates, lipids, proteins, clotting factors, bile, albumin, angiotensinogen, and the list goes on. Storage as well. So the liver stores glycogen, it stores vitamin A, vitamin D, B12, iron, and copper. And immune function as well. So the reticuloendothelial system, it contains a lot of immunologically active cells, and that acts as a sieve for antigens carried to it via the portal system. And it also produces proteins of the innate immune system. So just very quickly on anatomy. So this is the liver here, obviously, and then you've got your biliary system. So you've got your right hepatic duct there, your left hepatic duct, and then these drain into your common hepatic duct. And then this meets the cystic duct, which comes from your gallbladder. Gallbladder is a small organ which sits right underneath the liver. Then this leads into the common bile duct and then exits through your duodenum. So getting on to liver function tests. So I've put a little poll up of various things that will be included in a liver panel. So if you want to pop up the first question. So have a go at answering that and see how you get on. Okay, so it's quite close between A and C. So the correct answer to that is C. Correct answer to that is C. So a typical liver panel includes the following. So total protein, albumin, alkaline phosphatase, ALT, and bilirubin. Now, just close that. So the correct answer is C. So AST and gamma GT aren't routinely included, so they need to be added on where they're required, and it really depends on clinical context. So you don't always order them all routinely. The PT, or prothrombin time, is separately assessed in the clotting profile. So starting off talking about AST and ALT. So these both usually rise in conjunction with. AST normally rises in conjunction with ALT to indicate hepatocellular injury. So that's injury of the liver cells. It's usually very high in acute hepatocellular disease, but more modestly elevated in chronic hepatocellular damage and obstruction. It's also non-specific, so it's important to bear in mind that these two enzymes can be raised for other reasons other than hepatocellular damage. So one of AST's two isoenzymes is present in skeletal muscle, heart muscle, and kidney tissue as well. So these can all release AST too. So going on to the ALT-AST ratio. So either pop it in the chat or you can unmute yourself. So what might an AST to ALT ratio of more than 2 to 1 indicate?
So people are saying alcoholic liver disease.
Yeah, that's spot on. So AST greater than ALT is suggestive of alcoholic liver disease, especially if the gamma GT is raised as well. So an AST to ALT ratio of more than 2 to 1 is characteristic in patients with alcoholic hepatitis. Everyone has their own ways of remembering it. Personally, for me, when I've had a bit of a drink, I get really hungry and my favorite food's toast, and toast ends in AST. So that's how I remember, I associate alcohol with a raised AST. But like I said, everyone has their own ways of remembering things. So hope that might work for some of you. Most causes of liver cell injury are associated with ALT being higher than AST. So really, this is the main exception in alcoholic liver disease. So ALP rise in liver pathology due to increased synthesis in response to accumulation of bile salts. So it can be quite a useful marker of cholestasis. But again, it's quite non-specific. So there are various causes, various reasons why ALP might rise that are not linked to cholestasis. So these include the following: things like bone disease, renal disease, lymphoma, myeloma, infiltrative diseases, and it can rise naturally in pregnancy as well. So gamma GT. So what might an isolated rise in gamma GT indicate? So again, pop it down in the chat.
People are saying alcohol, fatty liver, alcohol.
Yeah, so same again, chronic alcohol excess really. So alcohol excess may also show an anemia with a high MCV. So that's a megaloblastic or macrocytic anemia. Folate deficiency is often seen in these individuals due to limited diets and various other factors too. The interaction between alcohol and folate is quite complex. Alcohol use, it doesn't induce folate deficiency per se, but it has been shown that serum folate levels will fall acutely after alcohol intake. So you can often see a raised gamma GT alongside a macrocytic anemia as well. So a gamma GT rise with a rise in ALP more than 3 times the normal is highly suggestive of a biliary tract obstruction, which you can call a cholestatic picture. Hepatic malignancies can also increase gamma GT. And there are some various other causes as well, things like COPD, renal failure, and following an MI. So the next thing on the liver panel, bilirubin. So hyperbilirubinemia, it may not always cause a visible jaundice. It's sometimes a lot more subtle than you might suspect, which is why it's important to do a very thorough exam. You may only see it on the sclera of the eye, so you can see that in the picture there, and it may not be obvious when looking at the patient from the end of the bed. An isolated rise in bilirubin, it's suggestive of a pre-hepatic cause. So with hyperbilirubinemia, it's really important to determine if it's conjugated or not. And you can do this both clinically and biochemically. So biochemically, you just measure the direct bilirubin component of the total bilirubin. And then clinically, you can ask about the color of their urine and stools. So this is important to know for OSCEs, and when you're taking history and in exams, they like to ask about this. So breaking down jaundice into 3 main categories. So if it's pre-hepatic, the patient will typically have normal urine and normal stools. In a hepatic picture, they'll have dark urine and normal stools. And when it's post-hepatic, so obstructive, they get dark urine and pale stools. I'm not going to go into this much more just because it's beyond the scope of this talk, but if there's one thing you remember from this slide, make sure it's that. So a hepatic picture, as we've discussed, so a rise in ALT and AST, which is known as transaminitis, is typically greater than the ALP and gamma GT. And various causes include the following. So alcohol, steatosis, viral hepatitis, and meds are all really common. And then you've got your other causes. The most common causes of significantly raised ALT are toxins. So that can be things like various medications, herbal remedies. Ischemic damage to the liver can cause ALT to shoot through the roof, as can some viral causes as well. Then you've also got your cholestatic and obstructive picture. So this is the converse. This is where ALP and gamma GT are greater than the rise in ALT and AST. And again, you've got a variety of causes there, some more common than others, but there are intrahepatic causes, things like PBC, drugs, PSC, and extrahepatic causes. Gallstones is probably the most common cause of extrahepatic cholestasis, where gallstones get lodged in the common bile duct and bile can't be drained away, which results in a jaundice. So there are various other ways that we can assess liver function. It's really important to do a thorough history and exam. So just another question. So what kind of important questions should you remember when you're trying to investigate liver disease?
So you should ask them about any itching, any high-risk behaviors, sexual history, alcohol intake, transfusion history, recent trips.
Brilliant, all brilliant answers. So what I was really trying to get at with that question is identifying specific risk factors. So many of you picked that up. So what are their regular and acute medications? Do they take any illicit drugs? Any herbal remedies? Are they at risk for viral transmission? So you said a sexual history. Have they had blood transfusions in the past? Is there any family history of autoimmune conditions? And what other comorbidities do they have as well? So how else would you investigate? There are various ways you can investigate liver function. So they include the following. So there's something called the non-invasive liver screen, or a NILS, and that's on the next slide. So we'll talk about that in a second. You can do a liver ultrasound scan. This can show any gross abnormalities and assess the size of the liver. You can do something called a Fibro Scan, which again, we'll talk about in a bit, but it's quite similar to an ultrasound, but it assesses the how firm the liver is. And you can do a liver biopsy as well. You shouldn't really do a liver biopsy percutaneously if they have deranged clotting, for obvious reasons that can cause massive bleeding and get you in a whole host of trouble. So going on to a non-invasive liver screen, or NILS, this is what it looks like. So on the left-hand side over here, you've got everything that you did in your LFT. You can pop them down there. You need to get information about the patient, like their age, weight, sex, etc. Then on the right-hand side, these are specific things that you need to think about and order. So you need to think about your viral Hep, so Hep B and Hep C antigens. You need to think about specific immunology, which you may see in various types of liver disease. And then you've got your immunoglobulins there. So there's a nice little cheat sheet really to help you out, reminding you what investigations you need to order for picking up various causes of liver disease. So I'm just going to touch on this. So hepatic immunology. So there are various antibodies associated with different liver conditions. So the first of which is autoimmune hepatitis. There's type 1 and type 2. In type 1, you'd expect ANA and or anti-SMA, which is smooth muscle antibody, to be positive. And in type 2, you might see anti-LKM1 antibody positive. Something called primary biliary cholangitis, or PBC, you'd expect AMA to be raised. In PSC, which is associated with ulcerative colitis, you may see P-ANCA raised. So these are kind of keywords that they like to throw in exams, and it's important to remember these. So essentially, that's interpreting LFTs in a nutshell. It can be a lot more scary than people think, but it's really not that bad once you put it all together with a clinical picture. So we'll talk a little bit about acute liver failure now. So what is acute liver failure? So acute liver failure, it describes the rapid onset of hepatocellular dysfunction due to a severe insult to a normally functioning liver. So the liver is known for its remarkable ability to regenerate, but sometimes the insult is so profound that that ability is lost due to insufficient synthetic and metabolic function. And then you can describe acute liver failure by its time frame. So if it's less than 7 days, it can be described as hyperacute. If it's between 7 days and a month, it's acute. And then 28 days to 6 months, it's subacute. Anything beyond 6 months, that's when you start talking about chronic liver failure. So causes of acute liver failure. What do we think common causes are for acute liver failure?
So overdose, paracetamol overdose, medication overdose. Yeah.
Okay, yeah, so people have hit the nail on the head there. The most common by far is drugs. It accounts for about 70 to 80% of cases. Viral infection is also important. Viral hepatitis is it's quite a significant cause of liver failure. Poisoning, immune and metabolic causes, and there are some others as well. Also cryptogenic, so where the cause isn't known. It's also important to bear in mind that is this truly an acute event, or is it an acute deterioration on a background of a pre-existing injury? So it's important this is why it's crucial to take history from the patient, gather a bit of information about their background, look through their notes, and so on. So in acute liver failure, the causes of death. So typically, those listed there are the common causes of death in acute liver failure. First one being raised ICP or cerebral edema. You particularly see this in paracetamol overdose. Sepsis is another common cause, multi-organ failure, and AKI. So these patients are typically very, very ill, and a lot of them need to go to ICU and escalated. So clinical presentation of acute liver failure. So quite often it's non-specific. So the presence or absence suggests chronicity, and patients are often unwell in a very non-specific fashion for a short period before the signs of acute liver failure develop rapidly. So there are some of the features that you might see. So jaundice. Jaundice results due to the inability of the hepatocytes to conjugate and excrete bilirubin, or obstruction to the movement of bile ducts by fibrous tissue. So when you get, when the liver starts to become damaged, the structural framework of the liver lobules can be damaged, which can then affect the outflow tract of bile. Coagulopathy typically results because the liver fails to synthesize adequate supplies of clotting factors. So you may get purpura, bruising, bleeding may occur, and raised INR. Edema and ascites typically arises because of the diminished production of serum albumin or hypoalbuminemia, and then this reduces the plasma oncotic pressure, which then draws fluid out into the tissue space. And renal failure can also develop. So there's something called hepatorenal syndrome. It's got quite a very poor prognosis. It's got quite a complex pathophysiology too, but it essentially results in hypoperfused kidneys. And a combination of liver failure and renal failure is not very good for prognosis at all. So these patients are very ill. And the last one, hepatic encephalopathy. So hepatic encephalopathy is a cardinal manifestation of acute liver failure. It results because toxic metabolites from bacterial breakdown of proteins in the gut, such as ammonia, they're typically metabolized by the liver, but obviously in acute liver failure, it's not going to be able to do that. So you get portosystemic shunting, and then these toxins end up crossing the blood-brain barrier and affect the brain in some very complex ways, which you definitely don't need to know about. So features of hepatic encephalopathy. So you'll see confusion, altered GCS. They may have asterixis, which is a liver flap. It's kind of an arrhythmic negative myoclonus type flap. They might have something called fetal hepaticus, which is a fruity breath. And it's not always done now, but I've seen it done just the other day, actually. Ammonia levels can be measured in hospital, and it would typically show a raised ammonia level. So I think the next, if you want to put up the next poll question, So hepatic encephalopathy can be graded, and some of you will have gone over this. So have a stab at that question and see how you do. Okay, so most people have gone for 3. The correct answer was 2. Okay, so the correct answer was 2. So the grading of hepatic encephalopathy is from 1 to 4. So grade 1 is irritability. They might have fluctuant mild confusion, slowing of mentation, sleep disturbance, slurred speech, and they can also get alternating euphoria and depression. So this is in the early stages. Then it can progress to grade 2, which is typically confusion and inappropriate behavior. The patients may appear aggressive at times. So typically they need to be managed by quite a few members of staff. Then when they get to grade 3, they start to become incoherent and restless. The patient's asleep most of the time, but they are arousable if you try hard enough. And then grade 4 is effectively when they're in a coma. So they're unrousable and they may or may not respond to different kinds of painful stimuli. So that brings us on to how do we manage hepatic encephalopathy? So again, do you want to pop in the chat how it's managed?
So there's various answers in here. Okay. There's a few people saying laxatives.
Okay.
And then tips and something called rifaximin.
Yeah. So, the most important thing, firstly, is to treat the underlying cause. Well done to those of you that said a laxative. So, lactulose is used. But firstly, patients with grade 3 and grade 4 hepatic encephalopathy, they should be managed in an intensive care unit. But you're absolutely right. So NICE recommend lactulose first line, and they also recommend rifaximin, as someone said. So this is an antibiotic which is given for secondary prophylaxis of infection. And then to whoever said a TIPS, you can do a TIPS, but this would obviously be after you try all medical options. It's kind of a last resort, really. And then you can also start thinking about liver transplant as well, but that's quite far down the line. So generally managing liver failure, acute liver failure, sorry, it's largely supportive. So this includes things like NG feeding. So they needed a diet high in carbohydrates to maintain their nutrition and prevent hypoglycemia. Prophylactic antibiotics and antifungals are important because infection is more common in acute liver failure. One of the reasons for this is that the liver isn't able to produce immunoglobulins anymore to help fight infection. Vitamin K may be used, and active bleeding may require FFP, clotting factors, and platelet transfusion. This is because you can get a coagulopathy, as we've talked about, with a prolonged prothrombin time and raised INR. And then in the scenario where you might get hypotension and hepatorenal syndrome, you may opt to use vasopressors as well. And sometimes dialysis is required too. And then as a last resort, liver transplant should be considered where there are no contraindications. So we're going to go through a case now. So a 19-year-old female is brought into ED by her friend at 8 p.m. and you're the F2 doctor in ED assessing the patient. So the patient reports intentionally taking 36 tablets of paracetamol earlier on. All the tablets were taken at the same time at around 4:30 p.m. She states that at the time she wanted to end her life, but now she regrets it. She's been feeling nauseous and she's vomited twice. She said that she feels a bit confused and a little bit drowsy. She's otherwise fit and well, no medical conditions or previous surgeries. She takes no regular medications and nothing over the counter. She's got no allergies. She lives at home with her parents. She's a student and attends college daily. She has no suicidal ideation at present. She denies previous suicide attempts, but she says she's not coping well and she's stressed about an upcoming exam. She's a non-smoker. She drinks occasionally, and there is no illicit drug use identified. So what do you do? What's the next step after you've taken the history from this patient?
Somebody said acetylcysteine.
Okay.
Bloods, measure paracetamol levels, acetylcysteine, take bloods. Yeah, that's about it. LFTs.
Would you jump in straight with bloods and treatment, straight after a history?
Somebody said A, B, C, D, E.
Yeah.
No.
So in any acutely ill patient, once you've taken a history, most important thing is an A to E assessment. So this is this patient's A to E assessment. So the airway is, she's maintaining her own airway. Onto B, she has good air entry bilaterally. Chest is clear, no wheeze or crackles. Her respirate's 20 and her SAT's 98% on room air. She has a regular pulse, and the rhythm is regular, and the heart rate is 96 beats per minute. Her blood pressure is 110/71, and a cap prefill time of less than 2 seconds. Random glucose 5.5. Her pupils are equal to light and accommodation. GCS of 15. Her abdo is soft and non-tender, calves are soft and non-tender, and she's apyrexial. So investigations. So I think we've got another poll, if we want to chuck that up on there. So which investigation isn't indicated here? Okay, should we end it there? Okay, so the majority of you went for the right answer, ECG. ECG, there's no real indication for it here. Paracetamol overdose doesn't really have much effect on the heart. It's really on the liver. So the investigations that you want to do are bloods mostly. So you want to do an FBC, a coag, blood glucose, LFTs, UNEs, and a VBG or ABG. You want to do a VBG, ABG to see if there's any evidence of acidosis, because paracetamol overdose can cause a lactic acidosis, and it also gives a lactate as well. You also absolutely need to do a serum paracetamol concentration, but this is typically taken at 4 hours after ingestion. You should also then consider repeating the paracetamol concentration at 6 hours after ingestion if the result at 4 hours is below the threshold for treatment. So these are the blood results of the patient in the case. So just take a minute to look at those. So FBC and coag are normal. Blood glucose seems okay, as do the UNEs. Bilirubin's fine. The ALT is very high. The AST is also very high. Gamma GT is normal. Albumin's normal. The INR's fine. There's no evidence of any acidosis, and the lactate's fine too. But the paracetamol level at 4 hours is 126. So what do we do next? So I heard a lot of people talking about N-acetylcysteine when we said what would we do. So that is correct. That is the drug of choice. This graph is called a nomogram or nomogram, and it's used to decide when to give N-acetylcysteine. So not all patients will need it. This is a graph which will help show if they do. So it's used to plot paracetamol concentration against time from ingestion. So if the paracetamol concentration lies on or above the treatment line, then N-acetylcysteine should be administered. It's used for patients who have ingested paracetamol over 1 hour or less and presented within 8 hours. As the concentration reaches its peak at 4 hours, it's important to take a level within 4 hours of the last ingestion as well. So the principal treatment of paracetamol overdose is NAC IV. It has multiple proposed mechanisms of action, but critically, it's a precursor to something called glutathione. And that means that administration increases the glutathione concentrations available to bind to something called NAPK, which is a dangerous metabolite. So in this case, the patient's concentration was 126 at 4 hours. So you can see this is already above the treatment threshold, which is why they would receive the N-acetylcysteine. So management. So most importantly, you follow trust guidelines. Every A&E department in the country will have guidelines on the management of paracetamol overdose. And there's a tool called ToxBase, which I'm sure many of you have heard of. It's very useful, and it should always be consulted for situations outside of normal parameters. So, for example, if a patient has taken paracetamol with a whole host of other drugs, you can consult ToxBase to see what they say. So activated charcoal, do we think that that would work with this patient?
People are saying no, only if present in less than 1 hour.
Yeah, that's right. So activated charcoal is pointless here. So the minority of patients who present within 1 hour may benefit from activated charcoal, but beyond that time period, it won't do anything. You should consider giving an antiemetic for the patient. If they're still feeling nauseous and vomiting, then you should provide symptomatic relief. And then N-acetylcysteine should be given if it's a staggered overdose. So what that means is if all the tablets were not taken within an hour, so regardless of plasma paracetamol concentration, if it's a staggered overdose, you should give N-acetylcysteine. If the plasma paracetamol concentration is above the treatment line, so it depends on the graph that you're looking at, and it will vary from trust to trust, but typically more than 100 milligrams per litre at 4 hours and more than 15 milligrams per litre at 15 hours. And if it's been 16 hours since ingestion and the paracetamol serum levels are still detectable, then you should be a bit worried. So N-acetylcysteine is now infused over 1 hour rather than the previous 15 minutes. Does anyone know why?
No answers.
Sorry, I didn't catch that.
No, there's no answers.
Okay. So the reason for this, so it used to be given a lot quicker, is because N-acetylcysteine can cause an anaphylactoid reaction. And it's more common than you think. It happens in about up to 30% of cases. So if this does happen, if a patient does have an anaphylactoid reaction, there are various things you can do. So the most important thing, firstly, stop the drip, stop the N-acetylcysteine. You can give antihistamines, you can try IV steroids, nebulized salbutamol if there's any bronchospasm. However, you should then start the N-acetylcysteine again at a slower rate. So it's important to know that a previous reaction to N-acetylcysteine is not a contraindication for using it again if necessary, because that's the only thing really which is going to reduce the paracetamol toxicity. So when would you consider a liver transplant? So there's a King's College Hospital criteria for liver transplant. There's one which is associated with paracetamol related liver injury and one which is non-paracetamol related. So you should consider it when the arterial pH is less than 7.3, 24 hours after ingestion, or all three of an INR greater than 6.5, creatinine over 300, and grade 3 or 4 hepatic encephalopathy. You probably won't need to know this for exams, but it's important to just keep it in mind. You should also check a lactate and phosphate. A low phosphate is actually quite a good sign. It shows that the liver is trying to regenerate using ATP, which then depletes the phosphate because that's used in the ATP. And then prognosis of acute liver failure. So it's not great really. It's around 50% even with good supportive care. And then once you reach grade 3, 4 encephalopathy, only around 20% survive without transplantation. So it is quite a serious condition. I'm not going to really go through this slide because it'd just be me reading it out. But here are a bunch of drugs and medications which can cause drug-induced liver injury. Some more common than others, but if you just, you can screenshot that or you can see it in the slides in your own time, just have a look at the various drugs which can cause a hepatocellular picture and the drugs that can cause the cholestatic picture. So we're going to finish with chronic liver failure. So chronic liver failure is generally defined as progressive liver dysfunction for 6 months or longer. It's increasing rapidly, largely linked due to the increase in alcohol intake, especially in the UK and places like America. The most common cause by far is alcohol, and there are other causes as well, including viral, metabolic, autoimmune, and some others. So it essentially describes the process by which there's progressive destruction and regeneration of the liver parenchyma by repeated insults. And then this leads to inflammation, fibrosis, and ultimately cirrhosis. So that's shown in the diagram there. You start off with a normal liver. Then this can progress to steatosis or fatty liver. At this point, it is reversible. It can then progress further to steatohepatitis. And then lastly, fibrosis and cirrhosis, by which point it's irreversible. And on the left here, we have what a normal liver looks like. And on the right, this is a cirrhotic liver. And you see all these nasty looking little bumps all over the liver. That is due to the regenerative, they are regenerative nodules as the normal liver architecture is replaced by fibrotic tissue. In chronic liver failure, you can also get something called portal hypertension. So portal hypertension occurs when the outflow of the hepatic or portal vein is blocked, and this can occur subsequent to pre, post, or intrahepatic abnormalities. And then this can result in various sequelae. So if it's of the rectal veins, it can cause hemorrhoids. It can cause caput medusae of the umbilical veins. But the most serious complication of this is esophageal varices. So when we talk about chronic liver failure, we can divide it into compensated and decompensated. So a compensated cirrhosis, it's typically asymptomatic as the liver continues to carry out normal function despite extensive damage. And then decompensated liver failure, this leads to multiple complications due to inadequate liver function. So things that can happen, so as before, you can get a coagulopathy due to reduced clotting factor synthesis, jaundice due to impaired breakdown of bilirubin, encephalopathy due to impaired detox of harmful substances, reduced albumin synthesis, and increased portal pressure can cause ascites as well. And then GI bleeding and varices. An increased portal pressure can cause these varices in approximately 90% of patients with cirrhosis will develop gastroesophageal varices over 10 years. There are some other complications as well. So bacterial infections are more common. Hepatocellular carcinoma is a long-term risk. It can also result in a dilutional hyponatremia and hepatorenal syndrome. And this is a picture on OGD of some of the varices you might see, and these are very prone to bleeding. And when they do bleed, it can be catastrophic. So clinical features of chronic liver failure. So early clinical features are usually non-specific. They include things like anorexia, lethargy, weight loss, hepatomegaly, pruritus, nausea, the list goes on. And then as patients develop more advanced disease, typical stigmata appear. So these are the type of things that in an OSCE, you'd be telling the examiner, oh, the patient has no evidence of palmar erythema, ascites, spider nevi, caput medusae, etc. And these are things that you should all be familiar with when going over clinical examination of a patient. So assessing severity of liver failure. So I think we've got one more poll question, if we could pop that up, please. So which classification is used for assessing severity of chronic liver disease? Okay, right. So if we end it there, so the majority have gone for the right answer again. So the correct answer is child Pew criteria. Duke's criteria is used for colorectal cancer. Fraser criteria is used for infective endocarditis, and Gleason grading is used in prostate cancer. And child Pew criteria or classification is the mainstay. Criteria used for assessing severity of chronic liver disease. There's another one as well, which is starting to be used a bit more and more, called the Model for End-Stage Liver Disease, or MELD. But for exam purpose, child Pew would be what I would remember. And this is the child Pew criteria. So it uses a variety of clinical and lab criteria to calculate an overall score. And then this can be divided into class A, B, or C. So those in class A have mild disease, and the 1 year survival is 100%. So they'll be okay for now. In class B, they have moderate disease. The 1 year survival is around 80%. And then in class C, in severe disease, the 1 year survival drops to 45%. So diagnosing cirrhosis. So you should be doing a NILS in all of these patients. Traditionally, a liver biopsy was used in almost all patients, and it is still gold standard, but it's associated with adverse effects such as bleeding pain, so not done as often now. NICE recommends something called a Fibro Scan, which we did mention before, and this essentially uses a 50 megahertz wave, which is passed into the liver from a small transducer at the end of an ultrasound probe. It's also known as transient elastography, and it effectively measures the stiffness of the liver, and that's a proxy for fibrosis. And then NICE have specific guidance on where it's used. So examples might include people with Hep C infection, men who drink over 50 units and women who drink over 35 units per week, and people diagnosed with alcohol-related liver disease are all indications for a Fibro Scan. And then some other investigations for cirrhosis or monitoring these patients. You should do an OGD to check for varices in patients with a new diagnosis, simply because if these varices start bleeding, the mortality is very high. They should have a liver ultrasound every 6 months with or without an AFP to check for hepatocellular carcinoma as well. And finally, going on to management of chronic liver failure. So you should always treat the underlying pathology, and this will prevent progression, and managing complications are the main aims. So prednisolone has been shown to improve survival for alcoholic hepatitis. A TIP should be considered in select individuals. A TIP stands for transjugular intrahepatic portosystemic shunt, which I know is quite a mouthful to say, but this is effectively anastomosing the portal vein with a hepatic vein to relieve portal hypertension. So it bypasses the metabolism in the liver and relieves the pressure. General measures include things like bed rest, sodium restriction, high calorie, high protein diet. If they have ascites, you can drain it, but you need to replace the fluid as well, because typically you can drain off a lot of fluid if they have quite intense ascites. And spironolactone is an effective diuretic and is a diuretic of choice in ascites. For SBP, which is spontaneous bacterial peritonitis, which is defined as a neutrophilic ascites, where the white cell count is more than 250, and E. coli is the most common cause, you need to give antibiotics for that. So you should follow your local guidelines, but cefotaxime is commonly used. Human albumin solution can help with edema, and an oral quinolone such as ciprofloxacin or ofloxacin provides primary prophylaxis.